Just to remind everyone, we do record these sessions and we do put them up on the AHI website. I ask everybody again, and I'll remind folks to sign in through the chat. Just put your name and organization. That way we can keep track of who's attended. And yes, it does. We also share with the ACO for their citizenship criteria. So that's something that's helpful for them as well. So good morning, everyone. As you can see, we do have an action-packed agenda and hopefully some great dialogue today around interoperability. We are going to start off with just some updates on PCMH. I think, and I'm going to look to Brenda, do we think?
Why don't we just hold off on the end, and Janet can always update us when she is able to get on. And I'll just send you, yeah.
Okay. Why specifically we wanted to touch base today around the PCMH is people are beginning to submit, and we're getting some feedback that there's some nuances that were unanticipated and not necessarily clear with NCQA. I realize that's a surprise for everyone that they're not super clear, but I would like to make sure if people are having any challenges, they at least have an opportunity to share that information so we can all benefit and we can do some follow-up. So I will just say, is anybody having any specific issues that they need assistance with? Okay. Well, Janet is going to hopefully join us, and she has some details about some specific issues that she's coming to encountered through submissions, so she'll share that. This morning, we are pleased to say that we have Laura Graham with us. She's the senior clinical practice advisor with iPro, and she very graciously has agreed to talk about promoting interoperability. So without further ado, I'm going to turn over to Laura.
Thank you, Luann. Good morning, everyone. Many of you know most of what I'm going to talk about, so what I thought I would do is kind of go through a refresher and add a little bit of what the new things are, just to make sure that you know everything about the PI category that you could know about it. So, Luann, if you would go to the first actual slide, that would be great. So the bulk of this is going to be a refresher for most of you, so we'll just go through it rather not too quickly, but a little bit with a little speed so that you're not bored. The promoting interoperability category, as you all know, basically is the main focus is to have solid exchange of health information using your electronic certified health record technology. We want to give patient access to their information. We want to exchange it between clinicians and pharmacies, and we want to have a systematic collection and analysis to be able to have good interpretation of health data. Next slide, please. So as you know, the category for traditional MIPS is that the category is worth about 25 points. When you're in an APM like Medicare Shared Savings, it's worth 30. So that's a main difference. Now, this is going to come into play later on in the discussion. So we're going to focus mostly on the fact that you're going to be submitting through the Medicare Shared Savings because you're required to. So there's a minimum performance period, as you know, of 90 continuous days at minimum, I guess. So you can do a whole year's worth of data, and many people do. But it can be any 90 days. It doesn't have to be a quarter, as we define that by the calendar year. But there is, you know, so you can go the middle of April to the middle of, what is that, July, 90 days. You know, you can do whatever 90-day period works for you. But all the measures for that category have to be submitted for the same 90-day period. So that's an important factor. When they use, when you do the measures, they're looking at performance-based scoring at an individual level as opposed to historical benchmarks like the quality category. They don't do that. and you need to have either a 2015 certified health record technology, or you have to be updated for the ONC Cures Final Act rules. It's going to be one or the other. You can, in the period that you choose, if you're in the transition process of updating, by the end of the period, the performance period you've chosen, you have to be certified to whatever you were looking to be certified in. So it could be that you're transitioning, so it might be a combination, but you have to be at least one of both of those things. If it's not certified information, then it's not data you can submit. So if you want more information about the ONC, you know, I didn't put that on the resources, but that'll be something I can, Luann, I can add to the resources and resend it to you. If you want to read more about what the Cures Act final rule is, or interim final rule is, you can get that information and I can provide a link to you. And if you would rather, Luann, I'll just send you the link. It's
sure.
Way. Could you go to the next slide, please?
Absolutely.
So you're in Medicare Shared Savings, you have to perform, you have to submit for the performance interoperability category. Unless you're a certain type of clinician, you have a special status, or you have some approved promoting interoperability hardship. So that's the, you can go to the next slide. Unless you're those three things, one of those three things, you would have to then submit the data. The people who are eligible for automatic reweighting, the certain types of clinicians, meaning you don't have to submit because you're a certain type of clinician, this is the list right here. And you can see that it's a small list of practitioners. The special statuses are right underneath it. So whether you're a qualified audiologist or clinical psychologist or PA or nurse practitioner, there's a group of you that wouldn't have to submit PI data. If some of those people are part of a practice, the practice would still submit. It just wouldn't, they would maybe include their data, or maybe not. It's aggregated, so you would. But if they're separate clinicians in their own practice, they don't have to submit. If a clinician has a special status, being that they're hospital-based, non-patient facing, or they're based at an ambulatory surgery care center, then they also don't have to submit. Let's talk about the PI hardship. People who apply for a PI hardship are usually individuals or practices that have no EHR, and they have a reason for that. They have difficulty with their EHR, they're in transition to an EHR, and it's too burdensome for them. There's definite reasons you can apply, but it's an application process. You have to be approved. And you want to make sure you don't touch that category if you do have an approved PI category or PI exception. Luann, could you go to the next slide, please? So performing interoperability participation requirements. In this case, you can see on the slide here, it says MIPS eligible clinicians and groups with MIPS eligible, I'm sorry, I wrote that wrong. It should be practices that are groups or MIPS eligible clinicians participating in a MIPS APM can apply for the hardship exception. This is where it's talking about, or they can qualify for the automatic reweighting, just like any other clinicians in, and this should say MIPS APMs. That's what that should say. So sorry for that. I'll fix that slide. If you're participating in an APM, you have the ability to again, be reweighted. You could have a PI hardship, but the APM entity can't apply. So it can't apply by itself as an entity for a PI hardship. The individual clinicians in the ACO or the APM can. So you'll receive, if you're participating in a MIPS APM, you're going to receive the APM's entity score. You'll be included in the calculation when CMS creates an average promoting interoperability for that APM. But if you have a PI hardship, your data won't be included, and it won't hurt the situation. Could you go to the next slide, please? And this is a little bit more about the performing interoperability hardship application. There's certain reasons you can apply, but the one thing you should note is simply not having an EHR is not considered an adequate enough reason. There has to be some other reason you have, you know, whether it's administratively burdensome or financially burdensome or some other situation. You have insufficient internet connectivity in your area. You know, or you have an EHR, but it's a decertified EHR. Being a small practice is one of the reasons, because of some of those burdens that do occur for small practices, being financial or administrative, that is sometimes considered a sufficient reason. So you would need to apply, and you would need to alert the ACO that you have applied and you have an exception. So it's important that you stay in communication with the ACO staff. You can go to the next slide. Oh, and the one last thing is I want to make sure you know this. The PI hardship, you can't get to January when it's reporting period and then apply. You have to apply before the end of the calendar year. So a PI hardship has to be done by December 31st of the performance year. Thanks. You can go back to the next slide. So we're going to talk a little bit about the measures. There's 4 basic objectives to the PI performance category. You have to do some work in e-prescribing, health information exchange, provider to patient exchange, and the the public health and clinical data exchange. Now, within the objectives, there are measures, and they could be 1 or 2 or 5 or 6 things to work on. In addition, you have certain attestations that you have to do around this category in order to say yes to certain. You have to say yes to certain things or true to certain things, and enter some numerators and denominators, and make sure you've hit all the parts. Because if you miss one of the required parts, you get a 0 for the category. And there's also one bonus to this particular category, and it is for prescription drug monitoring query. They've actually increased that. So that's new for 2021. It is an optional measure. The PDMP, or prescription drug monitoring query, you don't have to do. But if you do it, you have to do it with your EHR. Okay, next slide, please. So this is what's new for 2021. The health information exchange measures have been typically, for the last 3 or 4 years, hard to score well in. It's very hard to get direct emails and have that good communication with other clinicians. And as a result, CMS has introduced the concept of a bidirectional exchange measure as an alternative to the sending and receiving. Now, you don't do all 3 measures in the health information exchange objective. You either do the sending and receiving measures or take an exclusion, or you do the bidirectional exchange measure. So it's one or the other. And I heard on CMS did a webinar last week or the week before, and they did say this, and I asked the question, if you do all 3 measures, you will probably be defaulted to the bidirectional exchange measure for scoring. But I have not completely verified that yet, but I did hear them say that. So we believe it's a default to the bidirectional exchange. So that is something that is, I wanted to get a little bit of clarification on, but I want to also give you the heads up. So make sure you're choosing one or the other, the set of 2 or the bidirectional measure. The other thing that they did is in the HIE objective, they changed the name of the receiving measure. So it's now called Support Electronic Referral Loops by Receiving and Reconciling. And I think that used to say referral. So only the one word change, reconciling, is the new word. So, but we just want to make sure you know that they changed the title. They also, as I mentioned earlier, they doubled the points for the PDMP, or the Query of Prescription Drug Monitoring measure. And that's, again, a bonus. If you don't have to do it, but it's a way to get 10 points, which is really great, because in this category, you want to get to 100 points within the category. Although the category is weighted for ACOs at 30% of the total MIP score, within each category, they have their own scoring. So in the PI category, it's 100 points. The max of these points is 110. and that is reflecting the bonus for the PDMP measure. They also updated the certified electronic health record technology requirements and wanted to include what's going on with the Cures Act. So some of the changes that they have, they're allowing for those to be the status of your cert or EHR. It has to be certified either to the 21st Century Final Rules Act, a Cures Act of the and their final rule, or it has to be the 2015 Certified Health Record Technology. Next slide, please. And now I've told you some of this already. Now, one of the things you need to just pay attention to, and I've highlighted them in blue, the certification that you have, the functionality must be in place by the first day of your selected promoting interoperability performance period. It has to be in place, but the certification can be done by the last day. So it must be a product that's certified by the last day of the performance period, so that within the performance period, you've actually used whatever health record technology you're planning to use. And you need to use it for the full performance period. So I think that covers it. No, you can go to the next slide. 1, 2, next one. There you go. Now, you must submit this data, and I said this early on in a few slides ago, that you have to do for all the measure objectives and all the measures has to be the same 90 continuous day period. You can't do one measure from January to March because you like the score of that one and then do the rest from July to September. That's not going to work. It has to be all the same performance period. If you do the last 90 days in 2021, you have to begin that by October 3rd. And you need to have had your 2015 edition or the Cures Act edition. It has to be done and obtained by the end of the year for that performance period. Again, whatever performance period you choose, your certification has to be in place and certified by the end of that performance period. Next slide, please. Okay. So this is one of those mixed categories. It's not all numerators and denominators. The first thing you do when you go into the portal is you're going to put into that section of the portal for the PI is you're going to enter the dates of the performance period you want to report on. And then there's a series of attestations that you have to do. And then you get to the sections, the objectives. And some of them are numerators and denominators, and some of them are attestations. Or some, if you can't, are unable to, for some reasons, submit data for a particular measure and an exclusion is available, you have to make sure you hit that you're taking the exclusion. If you don't hit all of the fine parts that you're supposed to, and you miss one, I believe the portal, and my experience is that the portal has indicated that to you, that you've missed something. But if you leave it like that, because you can walk out of the portal and come back in at any point, and even if it's unfinished, if you leave it like that and you don't hit all the markers, your PI category will be 0. And that's important because that affects the ACO. Because if they're expecting you to submit PI data and you don't, it impacts the overall APM entity score. Okay, can you go to the next measure or slide, please? And here are the measures. So you need to just, I'm going to flip through these kind of quickly. This is the e-prescribing. You can see on the left, they tell you the objectives. The measures are in between. They give you a description of the measure in the middle here. And then on the far right, they'll tell you if there's an exclusion available. So you can get to know these measures with this chart. And if you want to slowly go through the other 3, I think there's 3 or 4 slides on this, you can see this one's the HIE. You have option 1 and option 2, and they do determine your option 1 is the 2 first measures. The new one is the option 2. And they sort of tell you what is available. With the HIE bidirectional, there is no exclusion available. It's the alternative to the other 2. So in a way, that's your exclusion. The public health data, the public health and clinical data registry exchange. This is a series of 5 registries you can choose from. What CMS is looking for is for you to be collecting data and reporting it to another entity, whether it's a CDC or some other entity where it is, you know, local health department, that it's helpful and your data is contributing to the data world in that respect of around that particular issue. So whether it's an immunization registry or a surveillance registry, you have to choose 2 out of the 5. If you don't have 2 that you're participating in, I would recommend you report the 1 and click on the 1 that you're attesting for the public health and clinical data registry. So this is an attestation. You'll attest to doing 1 and you'll take an exclusion for the other. If you're not in any, you have to make sure you take an exclusion for both. And for this category, the PI category, as well as the other categories, at any time, you could be asked by CMS to validate why you attested to or submitted the data that you did. So you need to have some information stashed, you know, in a file folder somewhere, that if that comes to fruition and you need to submit data to CMS validating why you did what you did, you're going to want to have that collected, and that's a really important thing to do. Okay, why don't you go to the next slide? I don't remember if there's more to this one. Okay, no, we'll go to this. One important thing you need to remember to do, and you have to do it before the end of the calendar year, is a security risk analysis. With the quality payment program and MIPS, you have to do a security risk analysis every year. For other programs like, and HEDIS, for instance, you don't have to do it every single year, but with the quality payment program, you do. So make sure you do that. It is an attestation. It is also an unscored measure. You just have to commit that you did it. And if you don't commit that you did it and you don't do it, you don't get a score in this category at all. This is a required area. They want you to make sure to do that. And if you need a link, Luann, that's another thing I can do. When I give you the CARES Act, I think I'll give you the website for the security risk analysis, because they have a really good tool on the website. And I'll make sure that I'll send that along as well. You have certain attestations with this that you have to do in the beginning, I told you, when you first go into report on the portal. And this ONC direct review is one. You need to attest yes to that. If you go to the next slide, Luann, that'll help. Can you go, let's see, I think you need to go back one. There it is. The prevention of information blocking attestation is one that you need to attest yes to, and you can read about it. And there's also, in the measure specifications, you can read about all these attestations. There is one that's optional. So that one, you know, it seems to be an optional attestation asking you to acknowledge that you're in good faith with the ONC surveillance and that your health IT is certified under the ONC IT certification. So that one I think is optional, and it doesn't require you to be yes. It can be whatever you need it to be. Okay, next slide. And this is the PDMP information, and I pretty much have told you everything there is to know about this. You cannot report, the one thing I didn't say is what you can't do is you can't report the optional bonus measure. If you claim an exclusion for e-prescribing, make sure that's in alignment. Most people do e-prescribing, so much so that they have really high scores. It's a high, people do really well. As long as your numerator is doing really, really close to your denominator, you're going to score fairly well on that. So if you're not choosing to submit that measure and you've taken the exclusion, you cannot do this bonus, though. So that's important. And I did tell you already that it's doubled its points, and CMS doubled the points this year from 5 to 10. Okay, you can go to the next slide. So these are the measures that you can take an exclusion for. And I just wanted to make sure you had a list of what they were. It's in the chart that I showed you before, but this gives you a quick, if you need to look and see this measure I'm struggling with, or I'm not doing so well with, or it's not collecting right, but the other measures are, can I take an exclusion this year? Well, you can know by quickly looking at this list. Okay, you can go to the next slide. Okay, so now we're going to talk about scoring. And I told you that the whole category is worth about 110 points. And that's because we have the PDMP bonus, and that's 10 points. When this program really began, I think they had so many different ways for you to score in this category that you could get a maximum of 140 points. It would, however, be kept at 100 points so they had all kinds of options. They have changed this category quite a bit over the time of the QPP. So it's now down to 110 points. Just a reminder, the security risk analysis is required and unscored. So it's not part of your score, but if you don't do it, you get a 0 for the category. And if you have an approved hardship exception, here's what I want you to know, and there's a reason why I told you about the portal and the first things you do. So when you go into the portal for the PI category and you enter the dates for the performance period, that's considered, to my understanding, that's considered submitting data. If you have a PI hardship exception approval, do not touch that category and don't put any dates in, because that could be considered by CMS as submitting data, and you will be scored and it would be 0, and your hardship exception would be voided. And I've had practices have that happen to them, and people on my team have had that happen a number of times. So you want to make sure you don't touch that category at all if you have an approved hardship exception. And then, as I said, you want to make sure that you've alerted people at the ACO level so that they understand and would not be expecting your data. Okay, next slide, please. So this is the measures, and I didn't want to go into depth about how this category is scored. If you look in the Promoting Interoperability user guide that CMS puts out, there's a very detailed explanation of scoring, but it's, at 8:30 in the morning, it's hard to wrap your head around math and algebra. So I just really wanted to give you what the point values were, and so this chart does that very well. And then if you had any questions about it, you can consult the user guide. You can call someone on our team at iPro, and we'll go through that with you. But it's a much better conversation one-on-one than try to tell a whole group how the math works. But it's so this is what the measure points are, and you can see prescribing could be up to 10 points, and you can be scored 5, 6, 4, 10, whatever, and you can add to that objective scoring with your PDMP there, and you can see how that works. So it's not hard to get to 100 points. It's entirely possible, and a lot of people score very high in this category because they have a lot of good direct email and their sending and receiving is good, but sometimes they would submit for the sending and they would not do so well with the receiving, so they take the exclusion. If you have less than 100 cases, you would take the exclusion. Okay, so rather than get into too much more details about the scoring, let's go to the next slide. So this is just reiterating a little bit about how to get scored in this particular objective. They want you actively involved with at least 2 different public health agencies or clinical data registries. That's what their goal is, because they think that's the threshold that would be very helpful. There's 5 different options they've given you, and you need to choose 2 of them. If you choose one of them, make sure you take the exclusion. And I know I'm repeating myself, but it's always good to hear it more than once because that's how it gets in your head. So if you don't have 2 registries or public health agencies you participate with, then make sure you take 2 exclusions and then have documentation that sort of validates that. You're only going to be attesting to yes or the word true. Sometimes it's a check mark. I forget what's in the portal, but as long as you have that in the area, and it's fun. The portal is very friendly. It's very user friendly. If you check 1 but you don't check 2, it does prompt you that you're not done, and you do have to go through the category and find which part you didn't do. Because I actually have done that with people. Like, wait, what did we miss? And so you can find easily that you do that. Now you are able to go in and out of the portal, and it saves automatically. It's kind of like what I love about Google is that it's an automatic save. The portal, the QPP portal is an automatic save. You don't have to submit, you don't have to do anything. And when you come back in, it picks you left off. But if you never go back in and they close the portal, that's your submission. And if it's not done, again, it's 0. Okay, next slide. And we're almost done here, just so you know. These are some of the reporting reminders that I always think are really helpful. Amidst data submission at the individual level must have all categories submitted at the individual level. That means you can't submit some at the group level because your practice scores better as a group, and then submit one measure as an individual. It has to be all individual, all group. And for the Medicare shared savings, you're supposed to submit your PI data, and Luann, you can confirm this for me, or Brenda, you're supposed to submit it all as a group, is my understanding. At least that's what we've worked with before. If you have the capacity, and Brenda and Luann can tell you better, if you have the capacity to, as an individual clinician, to submit your PI data, then that might be possible. But I'm pretty sure, do you want to weigh in on that? I don't know.
So we do not at the ACO level. Our providers do report their own PI individually. We're not part
Well, that
of
was my next comment. But when they do it individually, do they do it as a group in the practice or as an individual? That's the question I was asking.
Oh, so
or do they have the
I'm
option
sure, Angie, I'm going to pick on you. When that's at your level at Alice Hyde, you guys are submitting on the practice level, correct?
At the group level, yeah.
Yep.
That's what mostly we've recommended to most practices in ACOs. I just wanted to see if anybody else knew anything had changed. I never saw anything that changed, but we've always recommended that. But I didn't want to eliminate the possibility if someone did do it in their practice as individuals. But the responsibility lies with the practice for the PI category, not the ACO. So that's an important aspect. So if you didn't know that, and most of you probably do, but I just wanted to make sure that everyone knows that. So when the APM, when you're participating as an APM entity, the entity is going to submit the quality and the improvement activities, right? And that comes as an automatic. The MIPS eligible clinicians in the entity will be doing the submitting of the PI data. CMS writes it here as individuals or as a group. iPro has always been under the understanding that most people submit as a group. One, it's easier to aggregate the PI data in the group and just submit it. And a lot of times people score better, as opposed to if you have 7 clinicians in a group to do that submitting of data seven separate times it's just easier to do it as one group. So we've always recommended that, but CMS is saying here that you can do it as an individual. That's, I think, why I asked it, Luann. And then it's better for you to aggregate the data through your search and then submit the data as a group. And they will only score data that's been submitted and collected by the 2015 certified levels or the certified addition to the Cures Act. If you have and you submit data with multiple information, it'll be obviously separated out in the QRDA reports, but it's not going to be scored if it's not 2015 level. And you need to know that you don't need to submit any documentation. That's only if they ask you to validate it that you should have it. It's not at the time of submitting the data in the portal. So you just do the attestations, you put in the numerators and the denominators, and you should be set to go. Next slide. So here's a list. This slide and the next slide are the last 2 things I wanted to tell you. These are the things that we here at iPro think that are things to pay attention to. So it's kind of like a checkoff list. Review your measures regularly. Make sure, and I say regularly, I mean monthly at minimum. Make sure that receiving and sending is collecting. Make sure that your e-prescribing looks okay. Keep an eye on what those numerators and denominators are, because if something's going awry, you don't want to find it out in November when you can hardly do anything about it. You want to know along the way. Make sure and figure out what your performance period is. You can check different, pull down reports from different performance periods, different 90-day periods, and see. If you're doing all year, then it's all year. And you can see which way you score better. Sometimes you score better with one 90-day period than all year long. More is not always better. So you can choose one or the other. And you should pull those reports and see how the group scores that way. Check your EHR vendor and check with them, and make sure that things like your EHR dashboard is updated, that you know how to download a QRDA3 report, because then you can just upload it, and then you don't have to one by one put the mission. So the nice thing about the PI category is you can take a QRDA report and submit the PI category. And that is the kind of report that comes out of your certified health record, or you can manually submit it. So you can take the same information and put in the numerator, put in the denominator, do all the attestations. But if you have it set up in your EHR and you pull down the report, then the report will put all the information in for you when you upload it. So if you want to know how to do that, you should ask your health record technology vendor. And you should also just make sure you're at the proper cert requirements. Last slide, please. Make sure you do the security risk analysis by the end of the calendar year of the performance year. So 12/31/21 is this year. Monitor your PDMP report, pull a report, and make sure that the clinicians in your practice have all been, and you pull a report from your Department of Health. So in New York here, with the iStop program, you just go in, pull the report, and you get the patient list of who's been checked, I guess, or reviewed for in the iStop program. So that's something that you can do to make sure that it's going to be a full list. And then you'll have that actually is your validation by pulling that report. So if they ask you to validate the PDMP, you have that report. That's what you're looking, they'll be looking for that from the iStop program. So if you download one of those reports and stash it somewhere securely in your computer, then you can have it in, or a hard copy. But you should be able to, that's your validation to CMS if they ever ask you about the PDMP bonus. Make sure that you're reporting to a public health registry or know what, the exclusions. And then the last thing is make sure that your HARP account password is active and okay, because when you go into report in January or somewhere between January and March of next year, you just want to make sure that that password is up to date and not hard to get into, because you can do that ahead of time. Next slide. These are the resources I have for you. I can redo this slide and add a couple of resources to add the security risk analysis website in case you need to have that. And that, I think, is my last slide. So I went a little bit over, and I'm sorry for that.
No, this is great. Thank you so much, Laura.
So it's my pleasure, and I'm happy to answer any questions anybody has now or later. And the very last slide has my contact information on it. And you share these slides with everyone, right?
Yes.
So everybody has the ability to contact me or somebody on my team. The 866 number is a voicemail. You just leave it and one of us gets back to you. And we're happy to help. And, we're the free technical assistants. So don't hesitate to use us, because, we can answer questions or get answers if we don't know the answer. And we don't claim to know everything, but, we work really hard at knowing the answers. So let us know. So thanks very much for listening, everybody.
Yeah. So we'll open it up to questions.
This is Angie. Maybe I'll try my video too here. So you guys can see my sunshine. I'm interested in that bidirectional, that new measure, the bidirectional, and how we prove that or show that. We have different.
So you have to be connected to it. So there's a measure specifications. Can you go back up to the resources, Luann? Just go back 2 slides. The bottom reference here is all of the measure specifications. That's a zip file.
Okay.
And what you're going to do is you're going to go in and you're going to look for that measure specification on the Health Information Exchange bidirectional measure. And it tells you the details of how and what you do. So basically what you have to do is you have to be connected to a RIO, a Health Information Exchange in our state. So in New York State has Shiny, and then they have all the RIOs, and they're located in different sections of the state. You guys have to get into and be connected to there. If you can identify and have validation that you're in that, you attest to it. But you have to be able to validate that you are part of a RIO or some type of Health Information Exchange network.
Okay. All right.
Okay.
Yeah, we don't have great luck with our electronic exchange of information. We have another big entity to our west that tells us they don't get our messages, or they have no idea how to find our referrals when we send them direct. And it's super frustrating. I can't even believe that that's the truth, but that's what they tell our practices all the time. So it's a struggle. Yeah.
Yeah, I wouldn't deny that it is. I will tell you that it's something you have to document that you're part of it. You don't have to talk about the quality of what the part of it is. You have to talk about that you're part of it. And the part of the quality of that is the struggle and is the challenge and is the thing you're working towards. So I would say continue to work towards that. And I will also say that if an entity doesn't know how to find your information, there's just a disconnect that someone needs to get to the bottom of.
We've had,
but I would, as long as you can identify that you're part of that Health Information Exchange, though, that's important.
Absolutely. Yeah, we have HIXNY. We've had HIXNY for years. We utilize HIXNY. We have Medent, so we pulled information right to Medent from HIXNY. So we're good to go on that. Was really glad to see that, actually, because
yeah, I think it's a great flexibility, to be honest with you, because people have so much trouble with these two measures, sending and receiving. So,
okay, thank you.
You know, my pleasure.
Anyone else with any questions?
And if there's no questions, people can tell us later. You know, things come up. Sometimes once you digest information, something comes up. That's where you're going to use the contact information, and just call us and let us know. You have my direct line there. You have the voicemail. And the other thing you have there is that blue link is on our QPP website, iPro's QPP page. They have a way to ask for technical assistance there, and you can just ask your question there. And again, like the voicemail, we'll get right back to you within a day.
Great. Thank you, Laura, and thank you for putting these slides
My pleasure.
together. Yeah, we will share
pleasure.
them. I'll send them out to everybody, as well as we put them up on our website along with the recording for this. So people will have access to all the information. Once you send me the update, I'll go ahead and send them out and post them.
Okay, great. Thanks.
So I guess what I had sent out a couple of questions just to kind of spark some discussion if people, you know, are experiencing any issues with the interoperability, if your processes are not what you anticipate they should be, or if you're struggling with any of them, and certainly to the topic of direct messaging, if people have a process that they believe they can share that is working well so that people can hear that. And as well, I know that Medent, the team has joined us, and so I'm going to pick on Keith or anyone else that joined from Medent if you have anything additional to add with what Laura had presented.
No, I think she did a great job of presenting those measures and what really needs to be accomplished using direct in Medent.
Okay. And anyone?
Keith, this is Laura. Can I ask a question to Keith? Keith, is it possible that people have a way of manually entering if they can't? You know, I don't exactly, because I haven't used it, but I don't know exactly how people connect with other practices, but can they manually enter a direct email address? It was my understanding that Meta didn't have the capacity for that.
Yeah, there's two ways to do it. In Meta, when you're at the screen that you're sending the message from, you have the option to just type in an address right there on the fly. Or in Meta, you can create what we call a referring doctor file. If you store the direct address in there, you can send out to that referring doctor and that direct address you've entered, multiple by selecting them.
Oh, that's awesome. Okay, so that's great. Thanks so much for answering that, because I've heard both. I've heard mixed information, and it was my chance to ask you and get the clarity on that. Thank you.
And I'm just going to give a kudos to Medit too. They update the direct message addresses when they get them. I'm not sure how that's done, but I know it's done. Medit is not any ever of our issues with this. It's always the other end. So I just want to clarify that.
Anyone with other questions or comments, or do you have a process that you're utilizing that's going well? Okay, I believe Janet joined us, and I'm going to jump back up. We had talked about having just a few minutes to discuss some of the challenges with NCQA. Janet, are you available and able?
I am on.
Great. So I didn't give out details, Janet. I just kind of said you had identified some challenges with submitting. And so I'm just going to turn it over to you to share what you've discovered.
Absolutely. Thank you. So I have submitted for 2 practices recently, and there's 2 areas that the PCMH reviewer really pushed back on, and that was evidence for CC21A, which is showing your HCSNI interoperability. And so both of these things that I'm going to tell you about, the extra information they're requiring is not documented in the standards and guidelines or any of the information they have put out yet. So I really pushed back on that and said, you can't expect practices to know what they have to do if you don't have it in the standards and guidelines. I asked the guy, how would I know? And he goes, well, I'm telling you now. Well, I would rather have provided it beforehand. So with CC21A, they're really asking to see 2 examples of the practice information flowing into the HCSNI portal. So that means opening up the HCSNI portal and actually opening up one of your notes in the HCSNI portal, screenshotting it and showing that. They want 2 examples. You can also open up the medication tab and show that your meds are flowing in. You can open up the lab order tab and show that your lab orders are going in. And then they also want to see 2 examples of information that you're able to retrieve from HCSNI. It can be going into your EMR, or it can be from HCSNI, but it's obviously from outside practices. And again, they want to see that, not just that there is a document there, they want you to open that document, show them the note, or show them that med list that has medications coming from another practice or lab results that came in from another practice. So they don't just want to see that when you open HCSNI, that dashboard where it shows everything that's going on. They really want to see the meat and potatoes of what's in those documents. And then the other thing that they're also asking to see is they want to know the name of the practice staff that is logging in and verification of organization. So with HCSNI, that's actually tricky. I had a phone call with the guy to show him how HCSNI presents. Like, we don't have, when you open your HCSNI screen, it doesn't show your username or your organization or anything. So, but you can pull up your account and show them your login information. And I did push back and say, well, a lot of people don't use organizational emails because they don't have them. So what if they're using a Gmail or a Hotmail? And he said that if they are users in QPass, so contributors or administrators, it's fine because that will verify that email address. Or they will ask, push back and ask the practice for further verification that that person does indeed work there. The other area that I had issues with was QI, actually, and the worksheet, the spreadsheet for QI. They are now starting to push back and want to make sure that there's 30 people in the denominator for any QI measures. I know it sounds crazy, and usually you do have more than 30, but one of the practices I was working with is very new in seeing PEDS patients, and one of the measures we submit was just shy of 30 people in the denominator. And he told us to either expand the reporting dates to get 30 or to pick a different measure. And so I had a pretty healthy conversation with him, and he said it is not a hard and fast requirement, but that New York State and PCMH and CQA is really going to start pushing back to make sure that there are at least 30 patients in the denominator, so it's meaningful data. And my argument to him was that the first measure we did submit was meaningful. I mean, they have a total of 79 pediatric patients. They're trying to get it right from the beginning, and since they've been doing PCMH for so long, they do these PDSA cycles. And yes, there might not be 30 people in the denominator, but that's truly because that subset of patients isn't very robust yet. It doesn't mean that the practice isn't pulling good data and that the practice isn't doing a QI project. So those are the two things, really showing that extra data for CC21A and just making sure you have 30 in your denominator so they don't push back. I think there is still wiggle room to push back to your reviewer and say, hey, listen, we don't have 30 and this is why. But I mean, I personally rather not hear from them unless you're approved. So those are the two areas. And if you have any other questions about it, feel free to reach out to me.
Anyone with any questions right now? Have others been experiencing this that have been submitting? Not yet. Okay. Well, we do only have about a minute left. I don't know if there's any last questions or comments anyone has. Okay. I hope everyone has a great day, and we'll all talk to you soon.
Thank you, everyone.
Thank you.
Thank you.